truth and transparency is the focus of this session. And I was just going to go over the agenda very briefly. If y'all picked up a copy. The outline is that we're going to have a welcome by Ms. Cindy Johnson. But preceding her will be Beth Smith to go over the disclosure form if you're here to get a contact hour. Want to make sure we do all of those things in order. And then it tells you what we're going to do. We're going to have a presentation by Dr. Cindy Seiker. We're going to have some time for discussion afterwards, sharing ideas, and then an evaluation form. So don't leave before filling that out, please. And then we'll have some food for you and some networking time. So without further ado, Beth, if you can give the disclosures.
Okay, so I'm going to just read this document, which is required for any continuing education hours that we grant. And then I'll need someone to sign this at the end. So today's program is Healthcare Equity Training Session number 4. Cone Health is an approved provider of continuing nursing education by the North Carolina Nurses Association and accredited approved by the American Nurses Credentialing Center's Commission on Accreditation. The purpose today is for the learner to gain introductory information on concepts related to implicit bias and the functioning of medical systems on cancer patients. In order to earn your continuing education units, participants must attend the entire session, complete an evaluation, and sign or initial the roster. No influential financial relationships have been disclosed by planners or presenters which would influence the planning of the activity. No commercial support has influenced the planning of the educational objectives and content of the activity. And then again, a witness will attest that this disclosure was read by signing this form. So I'll have one of you as I come by. Your continuing education certificate I'll have for you at the end of today's presentation.
Welcome, I'm Cindy Johnson. I'm the nursing director for the Cone Health Cancer Center, and I've been given the privilege to welcome all of you to our 4th session of our healthcare equity training. It's been my privilege really to attend all of the sessions, and I can honestly say that it's really given me a whole different perspective of what our patients really and our community is going through. And I would just encourage every one of you to go back out from here and talk about how great this program is, to encourage people to attend, because it really does help us to understand true disparities, things that we don't really we think we know what's going on in healthcare, but from our patient's perspective, it really changes things. So I hope you will go out and talk about this program. I'm so excited that you're here today. I do have the privilege to introduce our speaker today. This is Dr. Sam Seiker. He is a professor of medicine at the UNC Chapel Hill. He's been a longtime faculty member of the Greensboro Area AHEC. He was named Associate Director for Medical Education for the North Carolina AHEC program. He has served 15 years of experience in healthcare services, research focused on improvements in chronic care, prevention, and reducing health disparities. He has also served in a leadership role as the Chief of Internal Medicine Program here at Cone and a residency program at Moses Cone. He is also Chair of the Practice Support Component of the North Carolina Healthcare Quality Alliance, and he's serving as the co-principal investigator for the ACURE program. I'd like to welcome Dr. Sam Seiker.
It's a pleasure to be here, and the main focus of today's meeting is I'm going to show you data about the Cone Cancer Center, and I'm going to start by just summing it up and saying it's good news. And so through the years, just to remind you, I didn't want to make this a total data blizzard, so I didn't put in a lot of the old data. But what we found when we looked at 5 years of retrospective data from 2007 to 2011 is that on average in breast cancer, African American women were getting a couple percent less surgery, a couple percent less radiation, and a couple percent less chemo, and we're dying at a we actually found some of that exaggerated even more greatly at other places. So it wasn't at the beginning that Cone was doing awful, but there were subtle differences in care. And for those of you who have attended other sessions, you've heard about some of the qualitative interviews about some of the differences in patients' perceptions of symptom management and patients' perceptions of some of their communication. And also the concept of implicit bias in systems, and that when we set up a system, it usually benefits people that we're more used to rather than people who are more outliers. And so really focusing on building systems to help patients get to the right outcome is really at the heart of this project. And so I'm going to go ahead and step through these data. And this is small, informal group. Please feel free to interrupt me at any time. And again, to remind you, the patients who are involved are patients with stage 1 or stage 2 breast or lung cancer, though the majority of patients in the study itself are breast cancer patients. So in a cure, the frank care interventions, to remind you again, are site-specific feedback where we let people know who are in the study how they're progressing with treatment data according to race. One of the big things in the study is the development of what we call a real-time registry, which actually extracts data from the EHR system for patients who are enrolled in the study. And if a patient doesn't come to an appointment, a warning comes up so that patient can be re-engaged. And if a patient doesn't reach an anticipated milestone in care, a warning comes up so that the care team can be re-engaged to discuss, well, was the care really supposed to go this way in terms of delays or not getting specific studies or treatments. And then we have enhanced navigation, and your navigator here is Beth Smith, who really has been terrific. And in the enhanced navigation, again, the navigator goes through a training to understand some specific cultural and ethnic issues, some specific atypical barriers that can come up in care. I mean, the story that I like to tell is that I had a lung cancer patient, 50-year-old guy who was very healthy, stage 1 lung cancer, and he absolutely refused surgery. And in talking to him, oh, I understand the prognosis, oh, I understand the surgery, understood everything. And then in questioning him further, the real reason he wouldn't go to surgery is because he was afraid if he was in the hospital for a long time that his wife would leave him. And so we brought in the wife and had a session where she agreed to stay, and he ended up going through the surgery. Of course, the tail end of the story is, it turned out the reason she was thinking about leaving him is he was a domestic abuser. And so even though she said she would stay, she did leave. So he got his surgery and she got out. So it was a win-win situation. But I mean, I understand that that's an ironic story. But the main point is when you talk to patients and ask them about doing things, do you actually get to that granular level to find out why the real things aren't happening? And again, particularly with African Americans and the history of African Americans and medical care in the country, I mean, there are issues of trust, there are issues of religion, there are issues of the feeling of being experimented on. And so there are just a lot of different things that people have to understand in order to be able to communicate some of this and get past the barriers. And then the other intervention are these health equity education sessions. And again, I actually give talks to groups of residents every week about health disparities in chronic disease management and go through that literature with them. And I tell them at the beginning of the session, my goal here is to make you paranoid. It's that you can see data about the care you give, and so I want you, when you see every individual patient, to think about what's the most ideal care I can give, and then try to achieve that ideal, although we know there are other barriers like economics, insurance, and other things. You determine the ideal care first, and then you deal with the other stuff. So, first care slide. So, in the total population, all years combined, this is a combination of the last 6 years dealing with 2,600 breast cancer patients. And you can see that the surgery rate now is, including the last 2 years, the surgery rate now is almost identical. So in the total population, this isn't just the people registered in the study. But there's another story to tell. And it's the story of what's happened over time. And as you can see, in 2009, and this is all breast cancer surgery. Lung cancer is a bit of a different cat in that breast cancer is much more risky. But if you look at this information over time, you can see that in 2009, the surgery rates were a little bit lower, a little more surgery in whites than African Americans, and then as you progress over time, something happened in 2012 and 2013 that showed big advances, especially African Americans. Now, maybe it's coincidental, but 2012 is actually when we started recruiting patients for the ACURE study. And before we recruited patients, we had several talks with staff members about awareness of the old data and these issues. So did that make a difference? Was that the main driver starting in 2012? I don't know yet, but we'll have some data later from surveys and other things where maybe we'll get a better take on that. So when we did a logistic regression for the total population over these years, what we found is that stage 1 patients were about a third more likely not to receive surgery. Now there's a double negative there, right? So what that means essentially is that the surgical rate for stage 1 patients was about 97%, which means about 3% didn't get surgery, whereas for stage 2s, which is a more extensive surgery, the surgical rate was about 92%. So it was stage 2, 8% no surgery, stage 1, 3% no surgery. So what may have happened there is just that either people had the attitude that they didn't want their breast disfigured, or because it was a bigger surgery, comorbidities may have played more of an issue in the decision making. And in the logistic regression equation, race didn't make a difference for surgery. So now I'm switching to the study. And again, patients for the study started to be recruited in 2012. And so this reflects the consented patients who came into the real-time registry, the system that I described with all the warning signals. And there are 112 breast cancer patients who are reflected in these data. And again, you see the surgery rate is pretty much even. not quite the 96% rate we're seeing in the total population. And logistic regression, there were no significant predictors of whether a woman would go to surgery or not. And I didn't, going back here, I didn't go through this well enough. So the predictors in the regression model were age, race, comorbid illnesses, the stage of cancer, whether or not a patient was married, and whether or not, so in the total population data, the only variable we had to reflect socioeconomic status was whether or not they had private insurance, whereas in the registry data, we'll be doing zip code related income later. We don't have that data yet, but the main indicator of socioeconomic status is educational level. All right, so no significant predictors for surgery. So now let's talk about total population data on completion of radiation after breast-conserving surgery. And one thing to note on this issue is that in breast-conserving surgery, radiation prevents local recurrence. There are no data that show that radiation therapy actually prolongs your life, though there's a thought that there's a very slight life prolongation. And so a strategy of breast-conserving surgery and mastectomy later isn't an unreasonable strategy given that data. But it's the recommendations are that women who are in their 60s or younger get radiation. And that older women can be treated with hormonal therapy alone. So you'd expect that it's mostly older women that don't get the surgery, don't get the radiation. So again, you can see that there's actually, in this whole population, black women are completing radiation more than white women, possibly reflecting an age issue, but that was not statistically significant given over 1,200 patients. But again, here's the time course. And so starting in 2009, you can see that in 2009, black women did pretty well, but the overall numbers were relatively low. In 2010, there was a bit of a flip in the data where white patients were at 87-ish%, black patients at 80%, and then in 2011, it flipped the other way. But starting 2012, the same year that breast cancer surgery went way up, the completion of radiation therapy went way up. And so is it to do with the knowledge of the transparency of the study, or is it just one of them things? But those are pretty good numbers. All right, now the logistic regression for completing radiation for the breast cancer registry patients, again, the stage of cancer was different, and so stage 1 patients were 2.7 times more likely to complete, and that makes sense because if you have a small lesion and you never want to lose your breast, then getting radiation therapy is likely to prevent local recurrence, and so it makes sense that you would be more aggressive with stage 1 lesions. Again, older women, older than age 65, was actually 66 and above, were nearly 3 times more likely not to complete radiation therapy. So again, that fits with clinical recommendations. And then race was not significantly different. And in the real-time registry, okay, I get it now. we're switching from total population to the real-time registry. I had to catch myself. And again, in the real-time registry, the completion rates for African-American women and white women were both good, comparable to national levels, with there being no disparity by race. And in the logistic regression, again, controlling for the things we talked about before, married patients were more likely to complete radiation, and there are a lot of studies show that that marriage sort of enhances care and outcomes, so that's not an unusual finding. But remember, I told you that instead of insurance, our socioeconomic indicator in this logistic regression was education. And so if a woman had high school education, or excuse me, greater than high school education, she was 13 times more likely to complete radiation therapy.
You've got nuts.
13, education greater than high school, more likely, nah, that's a mistake.
Okay, 'cause I was gonna say, it's really surprising. Yeah, I mean,
My mistake. I made this slide about 10 minutes before I came. But anyway, it's 13.4 times more likely to complete. Now again, remember, I don't have insurance in this. And when we did the initial data analysis way back when, we found that having health insurance was a strong predictor of completing radiation. And so education here and insurance may all be running together
Do you know
as well.
whether or not employed?
Pardon?
Employed?
Don't have that. Don't have employment on here. All right, and race fell out of the model as not being significant. So why is chemotherapy completion important? And so when we started this study, we knew both from home data and from national data that women get breast cancer surgery in the 90%. So we knew that breast cancer surgery, there wasn't going to be a big span where we could improve things. And we knew that, that radiation also, the adherence was pretty good compared to national frequencies. But completion of chemotherapy, I told you that radiation isn't a life and death thing, it's a local recurrence thing. Chemotherapy is life and death, in that in women where chemotherapy is recommended, the women who don't complete treatment are very much more likely to die. And by completion of treatment, we define that as being able to take 80% of the recommended treatments. And for breast cancer, it's usually 6 treatments for adjuvant therapy. So 5 of 6 is the standard. And again, there are strong national data that show African American women are less apt to complete chemotherapy and therefore more likely to die in similar stages of cancer. And so we really wanted to hone in on chemo completion. So in our old data, unfortunately, the most recent chemo completion data isn't available yet because we haven't figured how to get it exactly out of EPIC accurately. But we have several of the EPIC programming staff working on a report for us, so the next time we talk, we'll have these data. But from the old records, even though it wasn't clinically significant, you could see about a 3% difference in chemo between black and white patients. What do we have in the current consented patients in the real-time registry? 44 of 45 have completed chemo. with our little warning signs and our little navigator, and our navigator keeping people in the system. And for black women, that's at 100%, which is unheard of. And so I'm going to point that out one more time. And then talk a little bit about lung cancer and the total population data for lung cancer are pending. So I only have the real-time registry, and in the real-time registry, there are only 33 lung cancer patients, but there's certainly no black-white disparity in surgery. And just so you put that in perspective, nationally, the surgical rate for stage 1 and 2 white lung cancer patients runs around 76%. For black patients, it runs around 64%, and that results in an increased death rate of over 4%. So now a lot of patients are getting CyberKnife intended as curative therapy. So CyberKnife is stereotactic radiation. It's not a real surgery, it's a radiation treatment. And the data are pretty clear that in terms of 1-year survival, that CyberKnife is pretty equivalent to surgery, where when you start getting out 3, 4, 5 years, the lines start to spread a little bit. But I guess, so CyberKnife, the current NCCN recommendations for CyberKnife is that only patients who are not able to go through surgery should get CyberKnife therapy, but some centers really believe that it's the cat's meow, even though there aren't real big data sets that show that this is the way to go and it's an acceptable alternative to surgery in someone who's medically stable. That currently is not the recommendation. So in looking at total treatment, if we add CyberKnife to surgery, out of these 33 patients, only 3 of them have not received anything. And that is a total shift from when we first looked at these data back in 2005, where upwards of 20% of patients, 20 to 30%, got nothing. So this is a step in the right direction, though we still don't know that CyberKnife is really a standard. So we still have the question whether there's surgical underuse here or radiation overuse. National data suggests that about the right surgical rate is 80%. Okay, so these data would suggest that the surgical rate is a little too low. All right, so since we have a mix of breast cancer patients and lung cancer patients, we wanted to be able to look at everybody. And so what we did is we put together a variable called gold standard treatment completion. So again, for breast cancer patients who are supposed to get chemo, breast cancer patients who are supposed to get radiation, breast cancer patients who are supposed to get surgery. So anybody who didn't get surgery, didn't finish their radiation, or didn't complete their chemo counts in the no treatment completion group. For lung cancer, since surgery is the gold standard, surgery counts as the gold standard. This variable does not include stereotactic radiation as the gold standard because it's not recommended as the gold standard right now. So we terms of percentage of patients who are getting gold standard treatment, overall it's 78.4%. And you think, well, that seems a little low, but that also includes the older women who don't necessarily have to get radiation. And it also includes lung cancer patients who got CyberKnife but no surgery. So even though, you wouldn't expect this number to be perfect, because you expect some people to fall out because CyberKnife and not getting radiation is appropriate. But again, when we compare by race, and again, this is within the real-time registry, and we will run this later in the total population stuff, but in the real-time registry, there's no racial advantage for white patients. There's no disparity. And so within the work we've been doing in the last couple of years, there's no disparity. And then what predicts completion of gold standard treatment? And again, our socioeconomic indicator is education for this data set, and we'll be able to get income later. And age greater than 70, half as likely to get gold standard treatment. But again, for a lot of the folks who are, 80-ish, we don't want them to get radiation for breast cancer, and we don't want them to get surgery for lung cancer. So this in itself is not a bad thing. And we did control for health status, okay? So this is outside of comorbidities. And so higher socioeconomic status predicts more likelihood of getting these gold standard treatments. So from the data that we have so far, what do we know? We know that total population cancer care at home has improved substantially starting in 2012. We know that patients in the Accure real-time registry have completed recommended care at particularly high rates for adjuvant treatments, which were the ones we were really targeting. The most dramatic difference is the chemo completion for Black patients, going from the low 90s to 100%. And then SES issues still remain a concern, and over time we need to drill down on that better and try and make that analysis more granular. That's it. So what do you think? Questions? Concerns?